So let's talk about serologies and what we know from the literature about its use as a predictor of outcome. So a couple of papers, one in 04 and then a follow-up in 09 by Ippoliti, and also another paper by Kostas Papadakis in 07, actually an IBD journal, which actually looked at all of these markers as predictors of specific disease behaviors, including surgery and a more UC-like presentation in Crohn's disease patients. So these are all CD phenotypes. And first look at it as rows. If you look at ASCA, ASCA is a marker of small bowel, stricturing, internal penetrating, and small bowel surgery. So if you recall, I was saying to you that ASCA is kind of a more powerful marker of something going on at the level of the gut immunologically. One of the things that I find interesting is to go by column, and this is how I communicate to my patients, and why I was saying to you that perhaps the more immune responses an individual patient has, the worse it could be maybe for their prognosis, and that's because I feel like these immune responses are cries for help from the gut, meaning they're saying to you, I've got so much inflammation, my innate immunity is awful. I'm letting all this bacteria through because I can't fight off this bacteria, and my inflammatory drive is really high, and I need something that heals me ASAP. Okay, that's the cry for help that's the gut talking, by the way, in case you wanted to know. So this is internal penetrating disease, OMC, ASCA, and SIBR. So if you have a patient who's positive for all of these markers, particularly in our pediatric age group, we'll show you the data, but this is all adult data. The question is, should we be moving, right? Should we be, you should run serologies on your animals to see whether these animals are actually the ones that are progressing to stricturing. Are they immunologically different than patients, obviously, who don't go to stricturing, and whether these are a reflection of the specific gene-bacterial interactions. So another example is fibrostenosing disease, I2, which is not commercially available yet, but I imagine will be from a prognostic perspective. But ASCA and SIBR is also a marker of stenosing disease. And if you're I2 and ASCA, which will be available, as I said, you'll have more increased chance of surgery. So the question is, should we be acting, right? Should we be getting these at diagnosis as part of our profile for our patients? We get an endoscope, we look at the severity of the lesions, we do an exam, we look for perianal disease, we look at their age of onset, we look at whether we've started steroids or not. Should we be also looking at their immune reactivities as predictors of certain disease behaviors? So if you look at it another way, this is pediatric patients, so this is close to 800 pediatric patients. And what we said is that it's not just one marker that's a problem based on what Will Mao and everybody showed. We actually felt it's the number of antibodies or immune reactivity markers an individual patient has. So in a child who had 3 markers, they had a 6-fold increased risk of developing a stricture within 32 months from the time we initially diagnosed them. Is that a communication piece to a family in order to convince them to go to surgery? I mean, to go to biologic. But more impressively, because stricturing doesn't always lead to surgery, this is much more impressive when I communicate to patients, is once you start hitting above 2 markers, you have a 5 to 10-fold increased risk of developing internal penetrating. This is not perianal. This is internal penetrating disease leading to surgery. So the question is, if I have a child and or a patient, because I treat my adult patients the same way I do a child, but I'm expressing communication to a parent who's resisting me on the biologics, is do I use these in my ability to communicate risk of disease itself in order to get families to appreciate the importance of moving forward with appropriate early intervention? You can see, one, yeah, it's a 2-fold increase, but things significantly jump once you start having more antibodies in an individual patient. So this is SIBR, OMC, and ASCA, which are all something we actually use right now in practice. Okay. Extrapolating this to those antiglycan antibodies I was telling you about. And what this did was proof of concept. So this is using completely different antibodies, but the end result was the same. The more of these antiglycans you have, the worse the prognosis. And similarly, how high the immune response was. So it wasn't just okay to have, if you appreciate that ASCA's cut points are 20 and 40. So imagine someone who has an ASCA G of 80 and an ASCA A of 110. It's not just that they were positive, it's also that they were very high positive. So it's one thing for the bowel to say, I'm positive for all of these markers, but it's another thing for the bowels to actually say, I'm positive with high markers. That's even to me more of a cry to say immunologically I've got really not able to protect these bacteria, and I'm not able to mount an innate immune response, and I'm not able to mount an adaptive immune response, hence why the TNF's going crazy or whatever the actual immune reactivity or immune response in that individual pathway is for that individual patient. So here it's just showing you that this was a score using titer level or antibody level for these markers, and what this is just the concept being the higher the score, the higher the risk of complicated disease course, and the higher the score, meaning the height of the anti-glycan antibodies, the higher the need for abdominal surgery. So all this is saying, and all I say as well, is that I don't care if it's antibody A, B, C, if it's I2 ASCA, ALCA, AMCA, ACA, it doesn't really matter. It's a concept that there are immune markers of some kind of underlying innate immune defect that's saying the more of these you have, the more aggressive your disease is going to behave. And so how do we actually use these in clinical practice? So a lot of people will often say, yes, but your original studies were not prospective. They didn't actually measure the antibodies before a complication happened. So maybe those antibodies happened once you perforated, right? It was too late, meaning bacteria leaked across a perforation. Why wouldn't I mount an immune response? So what we actually said is, okay, we're going to take all patients who had serologies drawn before a complication and follow them over time prospectively to see whether truly there's a predictive ability of these markers. So one of the things that you can see is if you just focus, and what I often focus in my world when I'm talking to families is, and patients, I need to know what you're going to do in the next 24 months. This is the most critical period because one, drugs work a lot better if I use it within the first year or two. Once I start getting beyond year two, your response rates and your remission rates from what we know from clinical trials, and it probably is related also to the progression of fibrostenosing and stricturing that's actually happening in the mucosa over time. And like Peter and I were mentioning yesterday is that by the time some patients come to us, they've had the disease for years. I mean, it's not like you're getting them fresh, oh my goodness, Crohn's just started today, and you actually have the next 2 years to play. Often patients have already been underdiagnosed or misdiagnosed for a couple of years. And so the question is, here you have patients who are positive for all of these antibodies, meaning all three, that's the red, and you can see the drop-off that already by year two, almost 25% of our pediatric patients, this is from across the country, 21 sites, we all practice differently, etc., but the bottom line is that 25% of patients actually progress to surgery within a 2-year time frame. And if you could see at 5 years about 2 or 3 antibodies actually resulted in surgery. So if you wanted to look at 2-year and 5-year endpoints, that's how you can communicate. Now what we're doing, and what everyone should say, did this matter based on treatment, right? That should be the most important thing, is meaning, is this independent of treatment? We didn't have treatment data when we initially published this. Now we have treatment data that we're going back and looking at whether or not treatment actually influenced. And I do have the model, which Jeremy saw yesterday, that I will show you that treatment influences it a lot. I have one snippet to show you. The data's not quite ready, but I can show you that treatment influenced this group a lot in terms of the natural history. So the reality being is this is what happens, and so can we communicate to patients as to whether or not we can actually alter the natural history? And now that we have some predictive, and what they're doing now is in adults, they're validating this in a huge 700 patient surgical outcome adult population, so we'll have some ability to see whether this is true in adults, because often the diseases are different, but we want to know. We don't think so. We imagine it's similar because the original MAO data I showed you was adult, and then we switched to peds. And so the reality is, if immunologically, yes, peds are different less than 8 years of age, but above 8, they pretty well behave similarly in terms of their behavior. So let's switch gears a little bit to CBER and talk about colectomies and outcomes of the pouch, which is also a very big interest now because there may be a way to actually prevent complications of the pouch, which we never could predict before. So let's switch to pouch and UC-like behaviors for a moment. So remember I was talking about over here is UC P-ANCA, over here is Crohn's ASCA, and then there's everything in between. Well, this is an example of everything in between. This is a patient who's P-ANCA and CBER positive, okay? So a unique phenotype, because before I showed you ASCA, I2, OMC, that's a little bit of a different phenotype. Now we're talking about merging behaviors. We're talking about CBER, which is a Crohn's marker, and P-ANCA, which is a UC-like marker, right? And now you've merged them.